Everybody. Uh, this is a presentation uh, primarily on, I mean, not primarily, it is this particular presentation is only primary bone tumor. Uh, because there was just too much material to combine both soft tissue and primary bone tumors. So I thought we could maybe separate it out and do bone tumors now and do soft tissue tumors separately some other time. Is that all right?
Sure, sir.
No.
Yes, sir.
Yeah.
Yes, sir.
Okay. So we will do the way I have made the presentation is initially we just look at the the general approach, the presentation, the kind of radiological appearances, followed by a certain number of cases where there will be history, imaging, and then the histopathology appearance, and then we will do a small discussion. So bone tumors are either primary or secondary. We'll deal with the secondary tumors in the beginning and move on in detail to the primary bone tumors. The most common secondary tumors are metastatic in nature. Secondary tumors are also contiguously spreading from adjacent soft tissue tumors or are a result of malignant transformation of pre-existing benign bone tumors. METs are the most frequent malignant bone tumors. They predominantly occur in two age groups, broadly speaking, over 40 years and under 10 years. They are usually multifocal with a preference for hematopoietic narrow sites in the axial skeleton, cranium, ribs, vertebrae, pelvis, and in the proximal long bones. Metastasis to long bones, distal to elbows and knees are extremely uncommon, and occasionally they can be solitary, as is usual in metastasis from lung, kidney, and thyroid primary. Most common malignancies producing skeletal mets in adults, more than 75% originate from that's a mnemonic, prostate, breast, kidney, thyroid, lung, also colon, and melanoma. In children, usually neuroblastoma, rhabdomyosarcoma, and retinoblastoma. Radiologically, the mets may appear as lytic, blastic, but most commonly they appear as mixed. Okay, now so primary bone tumors are characterized by this list of factors. They occur during the ages of greatest skeletal growth activity, so therefore during the first 2 or 3 decades of life. The commonest sites are the distal femur and the proximal tibia, which are the bones with the highest growth rate. In certain bone tumors, you don't really need the pathologist if they are good radiographs and you have a good radiologist, experienced radiologist. The predominant nature of tumors that exist in bones are, benign tumors greatly outnumber the malignant tumors. Some of the benign tumors that we shall discuss are hamartomas like the osteochondroma, and the most common benign tumors are osteochondromas, non-ossifying fibromas, and enchondromas. Okay, some of these benign tumors can have a locally aggressive behavior, such as the giant cell tumor, which also metastasizes to the lung at times. Osteosarcoma and multiple myeloma are the most common primary bone tumors, followed by Chondrosarcoma and Ewing. Some of these tumors may dedifferentiate, so you may have a benign tumor which turns into a malignant tumor, or a low-grade malignant tumor which turns into a higher-grade sarcoma. High-grade sarcomas tend to arise in damaged bones, especially in adults, which are sites of bone infarcts, radiation-induced osteitis, or Paget's disease. Now, these are some of the relevant clinical pointers that one needs to keep in mind when discussing bone tumors. So, in terms of age, certain tumors are more common or tend to occur in certain age groups. So, in the 0 to 10 year age group, the most common benign tumors are simple bone cysts or an eosinophilic granuloma, whereas malignant bone tumors are Ewing's, leukemia, MET, or neuroblastoma. Similarly, in the 10 to 20 year age group, the benign conditions include non-ossifying fibroma, fibrous dysplasia, simple bone cysts, osteoblastoma, chondroblastoma, CMF, and the malignant tumors most commonly are the osteosarcoma, Ewing's, and adamantinoma. Similarly, 20 to 40 year age group, and then 40 and above. I'm sorry, these for some reason PowerPoint is not opening, and so there is a little bit of some of the words seem to have got mixed up, so you can't really see the columns properly. But 40 years and above, benign tumors are the osteoma, whereas all these are actually the malignant tumors: MET, myeloma, leukemia, chondrosarcoma, osteosarcoma, pleomorphic sarcoma, and chordoma. These are the most common bone tumors that you see in this age. So to summarize, primary osteogenic sarcoma and Ewing are the commonest bone tumors that you see in children and young adults. Chondrosarcoma in children and Ewing's in middle age are highly unlikely. Over 40 years of age, MET are the commonest skeletal malignancy, followed by myeloma, chondrosarcoma. Osteogenic sarcomas in this age group are generally secondary to damaged bone. In the 20 to 50 year age group, giant cell tumor predominate, occurs in skeletally mature patients, and is practically not seen in children or in patients over 60 years of age. Moving on to the other clinical pointers, pain. So, benign non-growing lesions tend to be asymptomatic and are discovered incidentally. Pain is a symptom of growing lesions. If there is a complicating pathological fracture or as a result of local tissue reaction. Some of the specific issues, growing lesions include locally aggressive lesions such as giant cell tumor, aggressive osteoblastoma, as well as malignant tumors. Osteoid osteomas are characterized by intense night pain, which is relieved by non-steroidal anti-inflammatory drugs. They can also, if located in the appropriate place, they can cause an inflammatory synovitis, which can obscure the fact of their presence, and so should osteomas should be looked for carefully in such situations. Between the enchondromas and chondrosarcoma grade 1, these are difficult to differentiate even histologically. Enchondromas tend to be asymptomatic unless associated with a pathological fracture, whereas chondrosarcomas usually are associated with pain. So, yeah, moving on to radiology. Okay, so The modalities involved in investigating bone tumors are the plain X-ray, the bread and butter investigation, CT scan, MRI, and bone scan or PET scan. CT scans provide info on nature of destruction, on particle detail, and in the assessment of matrix mineralization. MRIs are just an adjunct, and they are superior in defining the medullary and extracortical spread and the relationship of the tumor to critical neurovascular bundle. Okay, so what is the information that the clinician and the pathologist expects from radiology? Location of lesion, is it cortical, is it medullary, epiphysis, metaphysis, diaphysis? These are very important because they act as a means to shortlist your diagnostic category. Is there any evidence of pre-existing bone abnormality? For example, is there Paget's disease, or is there a bone infarct? What is the focality of lesions? Are they unifocal, multifocal, symmetrical, asymmetrical? Is the margin of the lesion defined? Is there sclerosis? Well-defined margins with sclerotic rims are strongly suggestive of benign, non-growing lesions, which means benign tumors. Is there any cortical expansion or destruction? Periosteal reaction? If so, what kind? Is there any mineralization or not of the matrix? And is there or is there not a soft tissue component? These are very important pointers towards reaching some kind of a differential diagnosis or an actual diagnosis. So in terms of location, certain tumors tend to occur in certain areas. For example, the Ewing sarcomas are in the most commonly seen in the hematopoietic marrow sites, in the axial skeleton, and in the proximal long bones, namely the femur and the humerus. Also multiple myeloma, leukemia, lymphomas, and MET. Non-ossifying fibroma tends to occur in the metadiaphyseal regions of the tibia and the distal femur. It is not seen in flat bones, craniofacial bones, spine, small bones of hands and feet. Similarly, simple bone cysts, chordomas, adamantinomas. Adamantinomas 90% occur in mid-shaft of the tibia, also in jaw bones. Chondroblastoma, long bones, generally in the knee area or in the proximal humerus. Giant cell tumors, also in the knee area. Knee area, as you see, is a very common site for primary bone tumors. And chondromas more commonly in the small bones of hands and feet. They happen to be the commonest tumor at these sites, and so on and so forth. Okay, so epiphyseal lesions tend to be chondroblastomas and giant cell tumors. Giant cell tumors can also extend into the metaphysis. Chondroblastomas are rare tumors seen in children and adolescents with open growth plates. And GCT is the most common tumor epiphyseally located in skeletally mature individuals. Similarly, metaphyseal intramedullary lesions, osteosarcomas, most common, also chondrosarcomas, fibrosarcomas, osteoblastomas, enchondromas, fibrous dysplasia, simple bone cysts, and ABCs. So metaphyseal intramedullary. Metaphyseal lesions centered in the cortex, classically non-ossifying form fibroma, and also osteoid osteoma. Diaphyseal intramedullary lesions tend to be Ewing, lymphomas, myelomas, uh,
Yes.
also fibrous dysplasia and chondromas. And diabetic lesions centered in the cortex are adamantinomas and the osteoid, which is this grayish lesion that is made out in this diagram. Okay. So moving on to the patterns of growth and bone destruction that you can make out in a conventional X-ray. Now, this is what is called a geographic pattern of destruction with sclerotic rim. A geographic pattern indicates well-defined conglomerate of lytic areas, and the sclerotic rim represents bone reaction to the lesion and is commoner in weight-bearing bones. 95% cases with this pattern are benign. Then you have again a lytic lesion or geographic pattern, but without sclerosis. This indicates rapid growth and also shows that the cortex has expanded. This is a permeative or moth-eaten pattern. You can see ill-defined zones of radiolucency, which, while there is a fracture associated here in this case, and these patterns are seen with rapidly growing lesions. I am not a radiologist, so I'm just giving you what I can see in these things, but finer nuances will be picked up by experienced radiologists. Okay, so when there is extensive destruction of both medullary and cortical bones, you see what is called the permeative pattern, which are multiple tiny. Can you see clearly? Hello? Are you able to see clearly? Is anybody listening?
Yes, sir.
So, I mean, you can see the images all right, right?
Yes, sir.
Okay. So, moth-eaten or a permeative pattern indicates destruction of both medullary and cortical bone, seen in high-grade malignant neoplasm and also in osteomyelitis. You can also see a periosteal reaction in this. Just outside the bone, you can see these hazy, vertical almost appearance of the periosteal reaction. So what sort of periosteal reactions can one pick up in a conventional X-ray? Slow-growing tumors have this typical solid or buttress type, whereas more aggressive lesions have produced what is called the Codman's triangle, which is the area between the arrows. Rapidly growing lesions penetrate through the cortex, separate periosteum, which induces the laying down of new bone, and is seen in malignant bone tumors, rapidly growing benign tumors, and reactive lesions like osteomyelitis. This is a typical hair-on-end reaction, usually seen in rapidly growing lesions, malignant lesions especially. Okay. Then matrix mineralization. Cloud-like or ill-defined amorphous densities with haphazard mineralization usually indicates osteoids, seen in osteogenic sarcoma. Chondroid matrix is recognized more easily on X-rays, and focal, stippled or flocculent densities, popcorn-like as they are typically called, or also lobulated rings and arcs of calcification. This is one situation where you do not require a pathologist to actually make a diagnosis of a chondroid lesion. So we go on to case 1. 17-year-old male with increasing pain left upper arm of 3 months duration and a recent onset of fever. Presented with swelling over proximal and mid-thirds of the humerus with local tenderness. The differential, therefore, was between a neoplastic process and osteomyelitis. X-ray showed an ill-defined, destructive, diaphyseal intramedullary lesion with a permeative pattern and a periosteal reaction. Can you make that out? Of hair on end. There was also soft tissue extension, which was much better demonstrated in the MRI. So what would you consider as a diagnosis?
Osteosarcoma.
Okay. Anything else? A young child presenting with diaphyseal intramedullary lesion, also with
Ewing sarcoma.
yes, very good, excellent. This is what the biopsy showed: small round blue cell tumor, no rosette, no necrosis, no matrix production, and 2 cell types: one dark, very hyperchromatic nuclei, and the other more vesicular with dispersed, blocky, almost blocky chromatin, occasional nucleoli. IHC cells were uniformly and strongly CD99 and FLE1 positive. They were negative for cytokeratin, CD45, S100, Despin, NSC, synapto, and chromogranin. These tumors can be positive for NSC and synapto. Okay, that we will discuss as we move forward. Okay, so the Ewing sarcoma family of tumors includes the Ewing sarcoma and the PNET group. The differential, histologically, the differential diagnosis is NHL, which is would have been CD45 positive. Rhabdomyosarcoma, which would have been Despin, myodivin, or myogenin positive. Neuroblastomas, which would have shown rosette and positivity for neurofilament, NSC, synaptophysin, and chromogranin. Small cell carcinoma, positivity for cytokeratin and also neural markers, namely NSC, synapto, and chromo. And a small cell osteogenic sarcoma. These do not produce a lot of matrix, but I mean, if one hunts, one can always find a small amount of osteoid production. They would be SAT-B2 positive and FLE1 negative. CD99 is a fairly non-specific marker in that sense and can be positive in multiples of situations, including osteogenic sarcoma as well as lymphoblastic lymphoma. So 80% occur between the ages of 5 to 20 years, very rare over 30 years. Most common sites are the diaphysis of femur, tibia, humerus, also pelvis and ribs. This is a gene fusion sarcoma and therefore usually has a very not really bland, but does not have a very pleomorphic appearance on histology. Characterized by the T1122 translocation leading to the EWS FLE1 fusion transcript. To complicate matters, sometimes these tumors can be CK positive, so differential of a small cell carcinoma needs always to be ruled out. Poor prognostic factors include large tumor volume at diagnosis and the presence of MET, which happens in 15 to 20% of cases. And response to pre-op chemotherapy is an independent prognostic factor. Necrosis greater than 90% is a good sign. Treatment strategy is preoperative NACP followed by surgery. Okay, this one, I did not have the radiology for this. This is a 24-year-old male with intermittent dull ankle pain for a period of 6 months. X-ray showed a well-defined expansile lytic lesion located in the distal fibular metaphysis with a sclerotic rim. So biopsy was done. What would you think of in terms of the radiological images? Benign, malignant?
Malignant.
But it has a sclerotic rim. Lytic lesion with sclerotic rim usually not seen in malignant lesions.
Giant cell tumor.
And cell tumor.
Could be, definitely could be. So histology showed a vaguely lobular lesion with hypo and hypercellular chondromyxoid areas with increased cellularity. This, I don't know if it's very clear, but if you can see, there is slightly more cellular or bluish nuclei you can make out at the margins. In the central area are collections of giant cells. And the other image shows basically the chondromyxoid matrix within which are stellate cells. Diagnosis, there was no mitotic activity, was zero, no hyaline cartilage was seen. It was all chondromyxoid. Diagnosis is chondromyxoid fibroma. It is again a rare tumor seen in young adults. Peak incidence is between 10 and 20 years of age. This is a neoplasm of incompletely differentiated cartilage, as in chondroblastomas. Location, most common location is knee, pelvis, small bones of feet, excuse me. Either in the metaphysis or metadiaphysis and often eccentrically located. Secondary ABCs are fairly commonly associated with this tumor. Differential diagnosis is chondroblastoma, which is typically located in the epiphysis and shows chicken wire calcification, which is almost pathognomic of this condition, and chondrosarcomas, which however show much more atypia and mitotic activity. These tend to recur and can be locally aggressive, but do not metastasize. Okay, so case 3. Thirty-year female, history of increasing pain in the knee over a period of 2 months, no associated effusion, serum calcium, phosphate, alkaline phosphatase levels are normal. X-ray showed a well-defined lytic lesion located eccentrically in the distal femoral epiphysis with, as you can see, metaphyseal extension and focal cortical thinning, no sclerotic rim. This is the gross photograph of the specimen showing a dark reddish brown, almost spongy cystic looking growth within the epiphysis and metaphyseal location. Histology showed this from the curettage that was done for the lesion. So diffusely distributed multinucleate histiocytic giant cells amidst the proliferation of gland ovoid stomal cells. The nuclear characteristics of the stomal cells and the giant cells tend to be very similar. Mitotic activity is variable, can range from very low to moderate. Atypical forms, however, are not seen. There may be areas of fibrous proliferation, areas of hemorrhage, hemocytic deposits, as well as features suggestive of aneurysmal bone cyst. However, in ABC, firstly, the distribution of giant cells is extremely irregular. Tends to be located within the septi or the fibrous tissues bordering the vascular spaces. But sometimes differentiating between the two, especially on a biopsy, can be practically impossible, especially if it is a solid variant of an ABC. So diagnosis for this particular case was a giant cell tumor. Okay, relatively common lesion, approximately contributes to 4 to 5% of all primary bone tumors. It affects skeletally mature individuals, females slightly more than males in the 20 to 50-year age group, located in the epiphysis with or without metaphyseal extension. The neoplastic cells in this condition are the mononuclear stromal cells. These express proteins suggesting a mesenchymal origin and a pre-osteoblast phenotype. They tend to be positive for, can be positive for CD68, and their role is to recruit vascular monocytes and induce them to proliferate, differentiate, and join in forming multinuclear giant cells through rank ligand and rank receptor pathways. Other mutations that are known in this condition include SMAD3 as well as P53, which attributes a worse prognosis to this condition. Approximately 50% occur around the knee, distal femur, proximal tibia, and proximal fibula, followed by distal radius and proximal humerus. Approximately 15% affect flat bones, the pelvis, sacrum, vertebrae. They tend to be rare in scapular location, in the ribs, skull, mandible, small bones of the hand and feet. Rarely are multifocal in location. In this situation, round tumor of hyperparathyroidism needs to be ruled out. Osteoid is not seen, but reactive bone formation is usually, not usually, but may be present and tends to be more frequent when there is an associated pathological fracture and is usually located towards the periphery of the lesion. Marked atypia, atypical mitosis, malignant osteoid or cartilage rule out this diagnosis. Vascular invasion can be seen in up to 30% of cases. It does not correlate with aggressiveness or the presence of pulmonary implants or pulmonary metastasis. Pulmonary lesions appear histologically benign and are indolent in nature. It is a locally aggressive tumor. Recurrences are common, and secondary malignant transformation can happen rarely. Long time or a long period after radiotherapy has been given to control recurrence. Malignant transformation usually results in a high-grade spindle cell sarcoma or an osteosarcoma. The differential diagnosis include ABC, aneurysmal bone cyst, giant cell ridge or telangiectatic osteogenic sarcoma, ground tumor of hyperparathyroidism, and fibrous histiocytoma 2. Okay, in terms of immunohistochemistry, the giant cells and the stromal cells are positive for CD68, and nuclear staining in greater than 90% of cases is seen in mononuclear cells for the antihistone H3.3 G34W antibody, which is a fairly recent antibody and useful in the diagnosis of giant cell tumors, especially when a differentiation from a solid variant of ABC is required. Surgery is the treatment of choice, curettage with cauterization or en bloc excision. where surgery may be problematic, radiotherapy and tumor embolization are applied. Adjunctive treatment with monoclonal antibodies, denosumab is another option. The mode of action is prevention of the rank ligand to rank receptor binding, and therefore proliferation, differentiation, and consequently bone resorption is prevented. Zoledronic acid, which is a bisphosphonate, is also a useful adjunct. It is a potent inhibitor of osteolysis and is capable of inducing stromal cell and osteoclast apoptosis. In fact, we have recently seen a case. We had a biopsy of a possible recurrent giant cell tumor, which is showing, similar stromal cells similar to what one sees in a GCT, but a complete absence of giant cells. And the patient has apparently received a full course of zoledronic acid over the last, I think, 6 months, if I'm not mistaken. And it is possible that the lack of GCT of the giant cells is because of osteoclast apoptosis. Moving on to case 4. This is a 14-year female, upper humerus pain with mild joint effusion. X-ray showed an irregular lytic epiphyseal lesion with surrounding reactive sclerosis, amorphous calcification, no cortical expansion, and no breach. Curettage was done, and this is what the slides look like. Cellular tumor with sheets of polygonal cells amidst chondroid matrix, many multinucleate giant cells. The nuclei appeared bland. They can be atypical, but usually tend to be bland but can be atypical. They show grooved or clefted appearance. Coffee bean appearance is what is historically they are described as. Mitotic activity is extremely low, and pathognomonic chicken wire calcification was seen around the cells. A diagnosis of chondroblastoma was made. So again, uncommon tumor, which is actually why I put it in. Benign, occurs 75% of cases occurs in the second decade. Males more frequently than females, and contains incompletely differentiated cartilage like in Chondromyxoid fibroma. Most common locations: long bones, epiphyseal, medullary, also flat bones including pelvis. Skull bones involved more commonly in older patients, and uncommonly can occur in patella or tarsal bones. Neoplastic cells are chondroblasts, stained with S100. Giant cells are, however, histiocytic and stained with CD68, pymentin, DOG1, and rarely cytokeratin can also be expressed. Chicken wire calcification is the defining visible feature, and secondary ABC-like changes are common, especially when the lesion occurs in the tarsal bone. Differential diagnosis includes GCT, giant cell tumor, chondromyxoid fibroma, and clear cell chondrosarcoma. Giant cell tumors tend to occur in clinically mature patients and generally have no chondroid matrix, are S100 negative. Chondromyxoid fibroma is metaphyseal in location and lacks calcification. Clear cell chondrosarcoma is epiphyseal, but in an older age group and with definitely malignant cartilage. In terms of behavior, these are benign tumors and are successfully treated with curettage. Radiotherapy is not indicated. Approximately 10% may recur and rarely produces non-progressive lung implant. Aggressive variants can be large and locally destructive, most commonly seen in the pelvis. Aggressive nature of the tumor cannot be predicted histologically. Okay. So, case 5. Eleven-year-old male with painful swelling above knee, X-ray, ill-defined destructive tumor, distal femur, fluffy radiodense calcification, soft tissue extension, which was confirmed on MRI. What would be your diagnosis?
Osteosarcoma.
Absolutely. Biopsy showed pleomorphic stromal cells laying down osteoid, nuclear atypia, increased mitosis, and a permeative pattern of growth. Here you can see lace-like osteoid. At times, malignant cartilage can also be seen. Malignant cartilage in this age group, one must consider chondroblastic variant and make a very, very intense search for osteoid if it is not easily found. So, diagnosis, osteosarcoma, high grade, most common primary sarcoma of bone. Peak incidence is in the second decade of life. Very few occur in children less than 10 years of age. And elderly osteogenic sarcoma is associated usually with a pre-existing bone disease. In locations in adolescents, young adults, the distal femur, proximal tibia, and proximal humerus, located in the metaphysis. In the elderly, it tends to involve the axial skeletal skeleton and the flat bones. Now, there are various subtypes based on its location. So, intramedullary can be intracortical or surface. The largest group is the intramedullary or central osteogenic sarcoma, conventional osteogenic sarcoma, and includes conventional high grade, low grade osteogenic sarcoma, chondroblastic osteogenic sarcoma, small cell, and telangiectatic variants. Other variants include fibroblastic, giant cell rich, osteoblastoma like, chondromyxoid fibroma like, multicentric osteogenic sarcomas, which has a very protean presentation. Appearances can be polymorphous, and diagnosis is not always easy because osteoids can sometimes be very hard to find. As you can see, differential diagnosis ranges from, it's very vast. Ranges from hypertrophic callus at one end, include myositis ossificans, aneurysmal bone cysts, osteoblastomas, giant cell tumors, to chondrosarcoma, undifferentiated pleomorphic sarcoma, dedifferentiated chondrosarcoma, Ewing, synovial sarcoma, as well as posterior mesenchymal tumor. There are no specific markers really for osteogenic sarcoma, and a final diagnosis needs to be made with the histological appearance and and IHC never in isolation. There are a variety of markers, osteocalcin, osteonectin, S100, and they can also be positive for SMA, NST, CD99, rarely cytokeratin, the EMA. You can see it's a very, very, just using IHC is not going to help you diagnose this tumor. SATB2, because it is a marker of osteoblastic differentiation, was at one point of time considered to be definitive for diagnosing osteogenic sarcomas, but is no longer considered to be so these days. IDH1 or IDH2 mutations usually suggest a chondrosarcoma. This would be valid in cases of chondroblastic osteogenic sarcoma, where chondrosarcoma becomes a differential diagnosis. Okay, in terms of prognosis, primary conventional central osteogenic sarcoma, very aggressive, very lethal tumor. Excuse me. Hello? Yes. Sorry. So, extremely aggressive and lethal tumor, primary relapse-free survival ranges from 50 to 80%. Patients who present with METs or at the time of first diagnosis or with recurrent disease, survival rate is less than 20%. Good outcome predictors are presence of localized disease, 90% or more necrosis with pre-op chemotherapy, and complete surgical resection. Poor outcome predictors are location in the proximal extremity, involvement of axial skeleton, large size or volume of tumor at presentation, detectable metastasis at diagnosis, and poor response to pre-op chemotherapy. Secondary conventional osteosarcomas, osteosarcoma in Paget's disease has a dismal prognosis. Median survival is just 8 to 21 months. Post-radiation osteogenic sarcomas, the prognosis is worse if locations are pelvic, vertebral, or shoulder burden. And in secondary osteogenic sarcomas, there is no correlation between response to pre-op chemotherapy and prognosis. Standard treatment is pre-op CT chemotherapy followed by surgery with wide margins. Biopsy tract must be removed with the tumor. Amputation is considered if major vessels and nerves are involved, or if the tumor involves regions which cannot be reconstructed. Pathological fractures or previous surgeries have contaminated a large volume of tissue. Okay, so So 45-year-old female with painful knee swelling increasing over the last 4 months, lobulated distal metaphyseal lesion, ill-defined with central stippled popcorn-like calcifications, peripheral lytic areas, and radiologically suggests a locally aggressive cartilage-producing tumor, very suggestive of malignancy. So This is what the histology looks like. Moderately cellular, lobulated, cartilaginous tumor, some endochondral ossification, moderately pleomorphic chondrocyte, binucleation is seen, mitotic count, however, was low. The diagnosis made was chondrosarcoma low grade. Uh, these tend to occur in the older age group, 30 to 50 years, extremely rare in children. And if a malignant cartilage tumor is seen in that particular, in children, chondroblastic osteogenic sarcoma, as I said earlier, must first be ruled out. Chondrosarcomas are the second most common primary bone tumor after osteogenic sarcoma, and they may be primary or secondary to sites of damage, similar to osteogenic sarcomas, or maybe as a result of malignant transformations in benign bone lesions. These are usually quite uncommon. Located usually in the trunk bones, pelvis, especially the ilium, the ribs, scapula, and also long bones, femur, and humerus. Aggressiveness can be predicted by histological grade, which is determined on the basis of cellularity, nuclear atypia, and the mitotic activity. Grade 1 tumors recur but do not metastasize. Grade 2 and 3, however, do metastasize. Mitotic activity generally is not very high in chondrosarcomas. Grade 3 chondrosarcomas usually have equal to or more than 2 per 10 high power fields. So if you see very high mitotic activity, chondroblastic osteogenic sarcoma, depending on age, or a dedifferentiated chondrosarcoma should be considered. IHC, not of much use. S100 is positive in chondrocytes, and P53 overexpression and high Ki67 proliferation indices correlate with clinically aggressive behavior. In terms of prognosis, histological grade is the most important predictor of metastasis. Lower the grade, better the prognosis, so inverse relationship. Overall, 5-year survival is 70% for low-grade chondrosarcomas and about 50% for high-grade. Tumors in the appendicular skeleton have a better prognosis as compared to those in the axial skeleton. Lower age and a low tumor volume also are related to better prognosis. In terms of treatment, irregardless of grade, surgical resection is the modality, and radiotherapy may be used as palliation. Okay, now this is the last case now, and is an extremely uncommon and unusual case, which I've included because we recently diagnosed this. 79-year female, pain in the right hip joint for a period of 8 months. Lytic expansile lesion was seen in the right lesser trochanter with cortical break, pathological fracture, as well as a small amount of extra osseous extension. A biopsy was done, which showed very non-specific sort of an appearance. There were these bland epithelioid / ovoid cells in a very vascular and edematous background. Some of the spindle cells also seem to be forming abortive blood vessels. Some of them showed at places intracytoplasmic lumina. I don't know if it can make, okay, or I can expand it. So you can see very bland looking cells, eosinophilic cytoplasm, all these blood vessels you can see there. And then at some places, you can see lumina adjacent to these, to the nuclei. We did an IHC. Almost most of the markers were negative. The only thing positive was CD34, FLE1, and also SMA, which was positive around the cell groups as well as around the blood vessels. Now, because there were so many blood vessels, diagnosis of hemangioma versus hemangioendothelioma of the bone was offered. Basically, a low-grade vascular neoplasm. The right proximal femur was excised. This is the appearance on cross. This is, of course, fixed, so it's all turned gray, but it was almost reddish brown in appearance when fresh. Occupied the entire intramedullary canal. There was a breach. It had broken through the cortical bone and was seen to be peripherally infiltrating the skeletal muscle. This is what the sections look like of this particular tumor. The bone sections are in process, so I don't have images for that. But it's apart, I mean, this one shows a more myoid appearance as compared to the earlier one, to the biopsy. But we'll see once the bone sections and everything comes in, then we will probably run some IHC and confirm. But it is an extremely uncommon lesion, a hemangioendothelioma of the bone. So that concludes the primary bone tumor lecture. We have still got a lot of lesions to cover, so aneurysmal bone cyst has not been done, even chondrosarcomas perhaps, higher grade, and a few others need to be covered. So we may do that in subsequent future lecture along with soft tissue tumors. So that's it for me. If you have any questions.
Thank you
Hello?
so much. Thank you so much, sir. If there are any questions, please mute and ask. I think there are no more questions, sir. So
Okay then.
thank you so much, sir.
So
Yes.
you let me know if additional, you want, when you want additional lectures, and we'll work that out. Thank you then. Bye bye.
Thank you so much.